You can see your chart, the same one that is in your text, with the seizure classifications. To your left, you see your partial seizures, and to the right, your generalized seizures. Let's look at partial seizures. Partial seizures, typically the person is conscious. Um, and then when you look down, you can have a simple partial seizure where the patient remains alert. And you can have a complex partial seizures where the person's level of consciousness is altered. So continuing on, your simple seizure, again, your patient is alert. They usually last less than a minute, and there's no loss in consciousness. Now, in your complex partial seizures, um, they usually last greater than a minute. Patients can become unconscious. You can see the patient, they can report, again, they can remain conscious but experience unusual feelings or sensations during the seizure. You may see them experience sudden and unexplained feelings of joy, anger, or sadness. In complex focal seizures, patients again have a loss of consciousness. You may see them biting their lip or moving around, like going through activities. You may see them looking like they're picking up items. Your text talks about on a grocery shelf. Other automatisms that you may see in a seizure may be picking at their clothing, fumbling with objects that are around them, or simply walking around. These seizures, again, they usually last a few seconds. Focal seizures, again, are typically confined to one area of the brain, but this seizure may spread and become generalized, because, again, we're talking about partial seizures. But if a partial seizure begins to involve more than one area of the brain, and you now notice a type of tonic-clonic activity with the limbs going on, this seizure, and if it's precipitated by an aura. And what is an aura? An aura is a warning sign that a seizure is about to happen. People can have auditory auras. They may hear things. They may have smells or tastes that warn them. And if a person gets used to experiencing an aura, they may be able to provide safety for themselves in the event that they know that a seizure is about to happen. So your text says any tonic-clonic seizure that is preceded by an aura or warning is a focal seizure that generalizes secondarily. So then it started out primarily as a partial seizure that became generalized. Your text says many tonic-clonic seizures they have started as a partial seizure in that patient. Other types of generalized seizures are listed in your chart, and they are your myoclonic, your tonic-clonic, and atonic seizures. Please look them up. Atonic is one that I want to bring to your attention. A is always going to mean without, so this person is without tone. That seizure may also be described as a drop attack. They involve either a tonic episode or a loss of muscle tone, and the patient really will fall to the floor. And you have to be concerned that if a person has an atonic seizure, that they can harm themselves. They can hit their heads. So you want to check that person for a concussion. When see if that person hit the ground, if they hit their head, if they're able to resume normal activity immediately. Patients with this type of seizure are at great risk again for head injury and often have to wear protective helmets. I once asked the doctor for a protective helmet when caring for a patient, and there was so much social, emotional stigmas associated with it that the parent and the child decided not to have it. But imagine all the research that we have about concussions and problems occurring post-concussion, that this is something you want to think about for the patient that has the tendency to have drop or atonic seizures. The other types, the myoclonic, tonic, or clonic, you're just looking at what's going on with the patient's body. Either they have periods of tone or they have periods where they are having jerking movements or activity during the seizure. And again, as the nurse, your job is to look at the amount of time a person has a seizure and what they looked like or what the signs and symptoms were during and after the seizure and how they recovered. What happened in the post-ictal state. So you've learned a couple new phrases. You've learned aura, a pre-warning or precursor to a seizure. Here's another one for you. How about post-ictal? Post-ictal. So after a person has a seizure, they will have a post-ictal phase or state. And what does that mean? So that post-ictal state, your patient will be confused. They can be very tired. They may have lost control of their bowel or bladder. They may have some frothing at the mouth. And that definitely happens in a tonic-clonic seizure. Patients are confused. And just to jump ahead with some of your nursing care, for this patients that after a seizure, you will want to provide them privacy. Again, my history is working as a school nurse and dealing with patients after they have seizures in school. So I would always make sure that family brought in extra sets of clothes. Imagine a child in class and they have a seizure and they're already embarrassed and now they have loss of bowel or bladder functions. So if you as the healthcare provider can provide them with privacy, allow them to change their clothes and they will be sleepy, allow them to rest, this will aid in that patient's recovery, develop of a rapport, relationship with you, and just their overall peace of mind. So let's look at the tonic-clonic seizure. And the tonic-clonic seizure is the first of the generalized seizures that we will talk about. Tonic. Muscles become rigid, stiffen, the arms and legs stiffen, and you can see that on video. You can see that in the next upcoming slides. These seizures can last seconds to minutes. When a person begins to have a seizure, you want to, if you're witnessing it, you want to find out how long that seizure has lasted. If a person has a diagnosis of epilepsy, they may have seizures or breakthrough seizures as their medications need to be changed, or if they forget to take medication, or as they grow and may require different amounts of medication. So anyway, if a person has epilepsy, you may see seizures. If they last less than 5 minutes, we don't always have to call 911. So if they last less than 5 minutes, even in the hospital, we document the occurrence, right? And we make sure that the patient is safe, but we don't always have to activate the EMS system if a patient is having a seizure. What are seizure precautions? So we have a patient that may be having a tonic-clonic seizure. What do we need to do for them? I'm always jumping ahead of myself. We're going to get to that in a couple slides. Okay, so tonic-clonic seizure used to be called a what? A grand mal seizure. So again, muscles become rigid, stiffen, loss of consciousness. They may fall to the ground. You want to make sure that patient is safe, followed by clonic activity. And so we go from being rigid to jerking of our extremities. So imagine that this patient is very tired. They've exerted a lot of energy. They may have pain and soreness after this type of seizure. If a patient has an aura or a warning of a seizure in a tonic-clonic seizure, we just want to have in our mind that this is a partial seizure that became generalized. Typically, this type of seizure is not accompanied by an aura. That's sensory warning. This picture is just giving you a depiction of the tonic phase and the clonic phase, what can be going on with the patient. Imagine a parent that is taking care of their child who has seizures like this. Imagine the fear that they would have. So support groups, careful patient information, and family, giving the family careful information about what is going on with the patient and how to provide for their safety is going to be vital. Okay, so now we'll look at first aid when a person is having a seizure. Remember a long time ago, we thought the patient was going to swallow their tongue. That's the reason why we put a spoon in their mouth or something. Not we, it was just what we heard, right? So why we put a spoon in their mouth so that they wouldn't choke or swallow their tongue. So first aid for seizures for the healthcare professional and that you will teach clients is very different. Okay, so if a patient is having a convulsive, generalized tonic-clonic, or grand mal seizure, we want to place them in the rescue position. You've heard that many times. You see in this picture that someone is providing a cushion around the patient's head. You kind of have a lot of people around, and I like this patient. Maybe we can clear the way. You see someone is there with their watch because we want to know how long the seizure is going to last. We also want to make sure that the patient is recovering and regaining consciousness after the seizure, or else they could be going into what we call status epilepticus, which is the emergency or life-threatening condition that can happen with people who are having seizures. So again, we want to place a cushion. We want to loosen, tighten clothing, and turn them on their side to prevent aspiration. As the seizure ends, we can offer help. Again, provide for privacy. Make sure you're looking up here. We don't put anything in the mouth, and we look for a medical alert. So a medical alert, you want to teach your patients that they should get a medical alert bracelet so that if they pass out, someone won't think that it's because of drugs or it's because other things make you pass out. What about diabetes or a heart attack? So if they know that you have a seizure disorder, they can monitor you and treat you accordingly. Again, we can look right here, a seizure that lasts more than 5 minutes. Are reasons to call an ambulance. If a person does not have a history of seizures, it has not been diagnosed, we call an ambulance. If they have slow recovery or a second seizure occurs, they could be moving into status epilepticus. Pregnancy or other medical diagnosis that could mean that the patient needs to be monitored closely, and we want to make sure that other things aren't going on. Let's say if the patient is diabetic, or if they have or if they're pregnant, we want to make sure the baby's okay. If they're diabetic, we want to make sure it's not caused by a low or high blood sugar. So any signs of injury or sickness, other causes. So in the hospital, first aid for seizures, make sure that you're padding side rails. We talked about this in class. Padding side rails, bed in the lowest position, have oxygen available at the bedside in case you need to suction the patient. Remember, you're not putting anything in the patient's mouth during the seizure, but afterwards the patients may have secretions they need you to help them remove. So oxygen should be at the bedside. And you are documenting the time of the seizure, the duration, if the patient recovered from the seizure, if any injury occurred during the seizure. Those are things that you are documenting as the healthcare provider. Okay, another type of generalized seizure is the absence seizure, or formerly called the petit mal. It's common in children. It lasts about a brief second. You may have seen on television or been as a child in class with students that the teachers say they just don't pay attention. They look like they're staring into space. They just blank out, right? So this could be caused from an absence seizure. So we want to assess the client for periods of blank staring, stare without moving. It occurs without warning signs, and it lasts less than 15 seconds. So this could happen over and over again. And remember, during your reading, you'll look at the fact that seizures, while that misfiring is going in the brain, they rob the brain of needed nutrients, and they can cause brain damage that lead to learning disabilities. So again, your absence seizure, a lot of times teachers or school nurses are able to see and to catch or diagnose these types of seizures, and they may occur up to 100 times in a day if untreated. So this is what your patient looks like during an absence seizures. Between seizures, the patient appears normal. You see they look engaged. They're reading their book. You could see someone sitting at home. They're engaged. They're reading their book. And then you look at them and they kind of look like a zombie. Vacant stare, eyes roll upward, eyelids flutter, cessation of activity, and lack of response. You can kind of snap your hands in front of them, but you will not get a response. We talked about partial seizures when we were talking about the different types earlier on, and this explained everything. Remember, partial or focal seizures cause focal irritations in the brain. You can see unilateral manifestations, localized brain involvement. It depends on the location of the irritation in the brain, the type of clinical manifestations that you will see occur in this patient. Again, they may spread to involve other areas of the brain in which we would consider them becoming generalized. Again, this person may have the feeling or sensation of smell or vision, and we said that that is called an aura. I like this diagram. It gives you an idea of where that focal irritation is occurring and what area of the brain and what signs and symptoms you will see. So if you look at the areas, I don't really want to write on here, but we say if they happen in frontal lobe, parietal lobe, near the temporal gyrus, it just lets you know what's happening. So the patient can have impairment of consciousness. Again, if it's superior temporal gyrus, you may see the patient having psychomotor phenomena, chewing movements, wetting of the lips. The patient can also have difficulty swallowing, bad or usual smell. If this is happening around the occipital lobe, form visual hallucinations. You may see patients with these complaints or these activities, and if it's happening near the parietal lobe, formed auditory hallucinations. They may hear music. Remember, patients can also have unclassified types of seizures. We talked about those seen post-fever with metabolic disorders, electrolyte imbalances, and heart disease, as well as alcohol withdrawal or genetics dysfunction. These can cause a missing flow of regulation in and out of the cell. So anything that can cause cellular metabolism to be disrupted in the brain can be a problem and cause the patient to have seizures. Now we look at your diagnostic tests. Please look at each one of these specifically if you have not already looked up what these tests are. Electrolyte panels, they may rule out metabolic disorders. Low sodium may lead to seizures. We can look at, it is definitely necessary that we do a careful history and physical so we can find out if there's any genetic predisposition, if the patient has any history of alcoholism, if they have any history of electrolyte imbalances, if they've had any trauma or concussion. MRI and MRA can rule out tumors. History and physical. In addition, it can look at genetic causes, and again, we're looking at sodium abnormalities for seizures. EEG, again, we said that is that primary or preliminary test that we do if a patient is complaining of and has had witnessed seizure activity. Make sure you look at the prep for an EEG. You definitely want that patient to have a clean scalp. These are electrodes placed with cotton and a substance to make them adhere and conduct that are placed on the patient's scalp. So you want to get a clean head of hair. You don't want it to be very oily. The EEG should be repeated. One test may not show seizure activity. It may be done awake or asleep. The room must be quiet. It may be dark, and the patient should be cooperative if you're having this test. They can have drug screens to see if there are toxicities or if illegal substances are causing the seizures. Spinal tap with CSF analysis can be done to see if the patient has some type of bacterial imbalance that's causing them to have seizures. Skull x-rays can see if there's been any traumatic brain injuries or fractures. And a CT scan can again show tumors or lesions that are on the patient's brain that could cause them to have seizures. Drug screens can look at illicit or prescribed drugs or overdose of drugs or alcohol. This is a tracing where the patient may have normal brain activity, and then they start having rapid misfiring of the neurons. You can imagine as you're looking at a strip that a person does an EEG and maybe they miss this area and this is all they see, and then they say this person doesn't have seizures, but right before they hooked up the electrodes maybe all of these things are going on. So that's why we need more than one EEG.